Bring him, ma'am.
So can I start?
You have your presentation with you, no?
Yes, sir.
So you can start sharing.
It's case-based, huh?
Yeah. First, it will be a case followed by
Then
the topic, approach to the topic. Okay, Dr. Aron, you can. So welcome to this edition of ISG PG Master Clinics. So today we have approach to abdominal pain. We have a case initially followed by the discussion. And Dr. Aron V. Thomas is presenting the case, and he will be subsequently discussing the approach. And we have two discussants who will be discussing the case. For the discussants today, Vishwas and
Dr. Sanjay, sir.
Are they available?
Yes, sir.
Are they
Yes, sir.
logged in? Vishwas is there? Who
Yes,
is-
sir. Sanjay, Dr. Sanjay.
Sanjay is available?
Yes, sir.
Yes, sir.
Okay, fine. Okay, Dr. Aron.
Sir, my slides.
The slides are not there. Okay, then I will upload. Don't worry. Is it visible?
Yes, sir. Yes.
Can we start then?
Yes, sir.
Yes, sir.
Yes, start.
Good evening, ma'am. Good evening, sir. Good evening to all. Myself, Dr. Aron V. Thomas from Vishwas Medical College. Initially, today my topic is regarding approach to abdominal pain. I like to begin with a case. So here is a 68-year-old gentleman present to us with complaints of abdominal pain for the last 2 weeks and yellow discoloration of sclera and dark color urine since last 4 days. So regarding his abdominal pain was a diffuse type. The incidence in the onset and gradually progressing, dragging and vague type of pain, non-radiating, initially more on the postprandial phase. Later, since last 7 days, it was continuous in nature, associated with decreased food intake. And pain, the severity of pain, initially it was 3 to 4 of VAS score, but later it increased to 6 to 7.
Okay, Vishwas, did you see this history?
Yes, sir. Yes, sir.
Are you happy with the history? Do you want any clarification here?
Uh,
You can switch on your video.
yes. I've switched it on, sir. Video has been switched on.
Are you switched on? Okay, we can see you. Now you just, you heard the story.
Yes, sir.
Okay, are you happy with
Yes,
this
sir.
story? Do you want any clarification? Because this is the only time we allow you to ask clarification. After that, we go into the discussion of the case, no? So the total duration
Yes,
is
yes.
68-year-old male with abdominal pain of 2 weeks and jaundice 4 days. Okay. This is a description
Yes.
of abdominal pain. Are you happy with this, or do you want any details? That's what we are asking. Sanjay, do you want any clarification?
Diagonal variation in nocturnal pain, nocturnal episodes.
No, no, there is no nocturnal variation. He doesn't get up from the sleep because of the pain.
Okay. No sleep disturbance. Okay.
Dr. Thomas,
Yes, sir.
Yeah.
Yes, ma'am.
pain, which pain, a dragging pain in the right hypochondrium would increase after a meal?
Cholecystitis pain, biliary pain.
What percentage of patients with gallbladder, dyspepsia, whatever you call it, presents with pain after a meal? What percentage?
Is it a regular phenomenon to have a pain abdomen or pain right hypochondrium after each meal?
Then
No,
all of
no,
us,
sir, no.
then all of us should get a pain, right? All of us should get a pain after a meal. So be very careful with that statement. More on postprandial phase. So what percentage of patients? It's a myth, This gallbladder pain presenting after a meal is all just a myth.
Yes,
It
ma'am.
is.
Yes, ma'am.
Then all of us should get a pain after a meal, right? If
Yes,
gallbladder is going to contract.
Yes,
So be
ma'am.
very careful with that statement. And then you're saying it's continuous in nature.
Yes, ma'am.
What is what an associated decreased food intake? Now, just describe what is it that you want to what do you want to concentrate on?
Ma'am, any vascular etiology?
Pain increasing after meal, continuous, and now it is associated with decreased food intake. What is it you want to convey?
Ma'am, actually, initially he thought that after food intake
The patient will say many things. No, what is your interpretation of this presentation that you have written here?
Ma'am, vascular etiology, any vascular mesenteric ischemia. So
Epigastric region. No?
Aron, see, the issues I will tell you. You have the advantage of having heard the entire story. You have the advantage of having examined the patient. Usually you will have the advantage in the examination. By the time you get to some sort of a conclusion, at that point of time, you have to present an edited history. See, this is a problem when you unedit a history and present. And see, you presented with abdominal pain and jaundice, and now your first impression is vascular. We are going miles away from the likely possibility. Understand? When you have abdominal pain and jaundice, we try to link it together. We don't bring any vascular, unless, of course, very extremely rare possibility hepatic outflow obstruction, etc., etc. Okay. So you have to be therefore present an edited story. That's most important. Edited story. Okay.
okay,
And removing all unwanted things, which probably you are not able to explain at all.
okay.
Okay. Doesn't mean you have to cook up and all. It has to be a correct story, but patient will be telling unnecessary too many details. Or if you ask for too many details also, they will tell. So we want only details which is pertaining to our problem, what we are going to deal with. Okay. And if you give too many descriptions, the attention, the examiners also will get a little irritated. You also won't be able to concentrate much. Ma'am.
Okay.
Any comments, ma'am, further?
Yeah. The dragging type of pain, where do you think it will radiate? You have a pain in the right hypochondrium, dragging pain. So I expect it to be hepatomegaly, or it's a gallbladder pathology.
Actually, you didn't say right hypochondrium, no?
This will not increase with food intake. This will not have nothing to do with food decrease, increase, nothing. But where will this pain radiate to? You said non-radiating.
Diffuse type of pain, ma'am, non-radiating.
Okay, Aron, there's a problem here. Where is the pain actually?
Ma'am, sir, it's a diffuse type of pain, sir.
That means all over the abdomen. You have to say that. I
all
can
over
have
the
upper abdominal diffuse pain. Entire upper abdomen. I can have entire lower abdomen pain.
All over the
That
abdomen.
means
He
entire
couldn't
abdomen. So
localize
you have to say abdominal pain, which was felt all throughout the abdomen, which was, that is the diffuse. Okay. Second thing is onset your return. Insidious onset, gradually progressive. Severity your return, dragging time. Yes.
Where's the location? Where's the location? It cannot be diffuse, no? Because it's a dragging pain. How can it be a diffuse pain?
Yeah.
How can it be a diffuse
What is the
pain?
difference between what is the dragging type of pain?
And what is a diffuse pain?
When you what is this dragging? You have to feel the drag at some point, no? Drag is not a diffuse thing. Understand? When you pull something, There's a feeling of something being pulled, the discomfort and pain associated with that. That is usually felt in a particular area, not the entire abdomen, no? So the description of the pain also should be near realistic as to what patient says. We got add on extra adjectives to describe it and make it complicated. Okay. So it's a one part agreed, you felt diffuse abdominal pain all over. Second, it is non-radiating. Okay. So when do you say this is the issue? If you describe a diffuse abdominal pain, which diffuse abdominal pain will radiate?
Exactly. Where will it radiate? And
Understand?
which of them
So
will
don't
cause
use
this?
unnecessary adjectives.
And
If you
which
have
will
got an
cause
upper
the-
abdominal pain which radiates to the back, or right hypochondral pain radiate in infrascapular or right shoulder region, or a loin pain which comes to the groin, okay, or hypogastric pain felt in the sacral region, or all those things, or lower abdominal pain felt along the inner aspect of the thigh. Those are the typical types of radiation which you expect along with abdominal pain. So don't bring in radiation unless it is relevant. Okay.
Is it a continuous pain from morning to night? Continuous pain?
Throughout the day, he had a mild pain, ma'am.
What I'm asking, is it continuous pain and disappears at night? It's not possible, no?
Ma'am, it was throughout the day, but it doesn't bother his sleep.
You have seen the case. You also know the investigation. You know everything. You have to build up the history to help us come to a reasonable diagnosis with just these 5 lines that you mentioned here. Okay. Because one is you're saying diffuse, then you're saying we do not know it's continuous or not, then you say it's dragging, and yet you've not localized the pain, whether it's right hypochondrium or upper abdomen, and you're saying there's no radiation. So all the 5 adjectives that you mentioned are not fitting with anything. I'm not able to even imagine which organ or viscous or hollow viscous or solid viscous that you're trying to describe. That's what I want to convey.
Okay, you described initially it is more in the postprandial phase. So what are the list of conditions which will go through your mind when abdominal pain is increased after food intake? First is a generalized question. Second, we will focus on to this case. What are the abdominal, which are the types of abdominal pain which is aggravated by eating food? Okay. Specifically, gastric. Okay, gastric ulcer, carcinoma of the stomach, agreed. Then what are the other conditions where pain will be aggravated by eating?
Pancreatic, no?
Pancreatic, vascular pain, mesenteric ischemia.
Okay, don't go for vascular immediately. See, you have been working in gastroenterology for 2-3 years, right? 2 years.
Yes.
So,
Yes.
how many cases of vascular insult you have seen so far? But how many cases of pancreatitis you have seen? How many cases of acute intestinal obstruction you have seen? Understand? So, when you say an answer, common things should come first. Rule number 1. Common things should be always mentioned first. Rare things to the pageant. Because once you break this rule, the examiners get a feeling that you are a pure theoretician. Your knowledge is purely from theory, not from ward work. Understand? They will assess your clinical experience by your answer. So you have to be careful about that. So probably, agreed, pancreatitis. Which type of pancreatitis? Acute. Okay.
Yes.
Then intestinal obstruction. Okay. Then, okay, mesenteric ischemia, accept. So it should not be the first thing. Okay, we'll go to the next slide.
No, 1 minute. Dr. Thomas, can you just revise your history now and just summarize what you want to convey? We've discussed so many. Can you just quickly tell us?
Redraft your history. Redraft your history. Represent your history.
Okay.
Can you just revise that history?
This
Yes.
is a training, not teaching, training. So we have to redraft how you are going to represent it.
Reframe the history, these 4 lines that you mentioned.
Diffuse type of pain, incidence in onset, continuous type, and a pain score of it was mild to moderate in intensity. Mild initially, later it will become moderate.
I just again revise it. When all can you get a continuous pain and a diffuse pain? List few causes, Vishwas. When all can you get a continuous pain and a diffuse pain?
You understand the question? which are the situation you get a continuous type of pain abdomen.
Continuous pain and a diffuse pain, diffuse and continuous.
Mummy.
Perforation.
Isn't it?
Perforation. But will perforation patient will live for 7 years without without intervention?
Peritonitis, that's all. It's all acute.
Something would have happened, no? If the perforation is not diagnosed and peritonitis has set in, that is purulent peritonitis or perforation, unless something is drastically done, the patient will die of septicemia and shock. Okay. So it's an acute emergency. Okay. Okay. In the first 24 hours, it may not be diagnosed and the patient may present with severe diffuse type of severe pain. Agreed. Peritonitis. Agreed. Okay. Anything else? Continuous pain. What are the diseases which will produce continuous pain?
You know, if a patient wakes up in the morning and says, I get pain at 6 o'clock until I go to sleep, then they're all malingering, right? And they sleep off nicely, comfortably for 8 hours.
What are the characteristics of a hollow viscous pain?
Spasmodic.
In the hollow viscous, generally the small tubes like small intestine or large intestine or because stomach is, even though it's a hollow viscous, it generally doesn't behave as though it is like a small pipe. Okay, because it is capacious. So so to produce obstruction, a significant portion of it will have to be blocked. But for small intestine, it is easy to get blocked because the lumen is less in diameter. Okay. Similarly, colon, right side the diameter is more, left side the diameter is less. So left side of colonic obstruction will be earlier compared to right side. Okay. So when there is an obstruction, one of the methods of circumventing it is by vigorous peristalsis. Okay. So that is why you get a colicky abdominal pain. Understand? So when you take food and when the food reaches there, it's not able to pass through the narrow area. There will be vigorous contraction of that part of the intestine, which will try to overcome the obstruction. That will be felt as the abdominal pain. And along with that, the patient may also feel borborygmy. And if there is a certain segment of the small intestine which is getting in that obstructed area, it may produce a ball rolling sensation as well. Okay, so these are the associated features. We have. Okay. Another thing, dull aching pain or continuous pain. Can you get in pancreatitis, chronic pancreatitis or pancreatic neoplasm? A complicated pancreatitis, one may expect a dull aching pain throughout, like a large collection. Or a CA pancreas, the advanced, that may be continuous type of pain, or a mesenteric ischemia, the acute type, where there is a significant ischemia, the pain may be continuous, especially when it goes towards gangrene, etc., etc. So there are only few situations where you get continuous diffuse pain. Continuous diffuse pain. Peritoneal disease, maybe ischemia of acute type, because chronic ischemia is again generally related to food intake. It is called mesenteric angina. Okay, it happens only when the person takes the food. Okay, ma'am, can we go? So next slide. Next slide is actually not abdominal pain. It is mostly jaundice. Okay, so this is called an associated symptom. Whenever you have a patient with abdominal pain, you have to actually look at the description of the abdominal pain first, most importantly. Okay, site, the nature, the duration, aggravating factor, relieving factors, then associated symptomatology. So I will ask a theory question. Vishwas, what are the associated symptoms one should seek for when you have a patient with abdominal pain according to the site of abdominal pain, upper abdominal pain? What are the associated symptoms which you will ask for?
Whether the pain aggravates on having food, sir.
Okay, that we already discussed. Okay. Food aggravates. I am telling you about associated symptoms. Earlier we were discussing about the features of pain. Now associated symptoms. What do you mean by associated symptoms?
With the pain, what are symptoms appearing, sir?
Because associated symptoms are some other symptoms which is related to the organ which is involved. For example, what is the associated symptom here? Jaundice.
Jaundice, yes.
So when the jaundice is there along with abdominal pain, our attention straight away goes to the hepatobiliary system. Understand?
Yes.
When vomiting is there along with abdominal pain, our interest will be to see whether there is a gastroduodenal obstruction or upper small bowel obstruction. If there is abdominal pain associated with colonic symptoms, either in the form of constipation or diarrhea, so it has to be colonic type. Or if there is an abdominal pain associated with urinary symptoms, or if there is an abdominal pain associated with the bleeding, PV, or during menstruation. So these are the symptoms which we will try to locate the organ. Understand? So you have to look at the associated symptoms also. Okay. So first is all characteristic about the abdominal pain, 2 associated symptoms. So Vishwas, Aron just describe the jaundice and Vishwas will have to say, can he get anything out of it?
So patient had jaundice which has insidious and rapidly progressive in nature. It was there for the last 4 days, associated with dark colored urine, not associated with itching or clay colored stools or any.
So this is just a jaundice which occurred about 3-4 days after the onset of abdominal pain.
Yes.
What are the situation you get to this sort of abdominal pain and then jaundice like this? Can you think of some condition?
Hepatitis, viral hepatitis.
Viral hepatitis. Okay. But will abdominal pain will be that severe to present in a viral hepatitis?
Not very severe.
We have seen many cases of hepatitis A, hepatitis E, hepatitis B, etc. No? But how many
Yes.
of them present with a significant abdominal pain as the dominant first complaint?
Very.
What is the
very
usual
much.
presentation of a viral hepatitis, the garden variety? How does it present to the hospital?
Prodrome.
Usually a prodrome characterized by
Fever, myalgia,
fever,
decreased appetite, nausea,
diminished
generalized
appetite,
weakness.
nausea, vomiting, and myalgia, especially if it is hepatitis B, myalgia, arthralgia. Okay. Then after that, then jaundice. First,
Jaundice.
dark colored urine, followed by coloration of the eyes and skin, clear and skin. This is the pattern. And sometimes they may have a dull aching pain. It is extremely unusual to have very severe pain as a presenting feature of acute viral hepatitis, the usual type. Okay. Some hepatitis, some sort of acute inflammation of the liver may present with pain, but that is not the viral hepatitis. Okay. So, which are the other conditions? Pain and pardon?
Choledocholithiasis. But
Choledocholithiasis. Okay, agreed. It can present with the pain and then jaundice. But did you describe the classic pain of choledocholithiasis? Can you describe that? Shetty, Vishwas Shetty.
Yes, sir. Yes, sir.
You are not visible. Can you switch on your video?
Yes. Sir, right hypochondrial to epigastric, radiating to the back sometimes.
It need not always be. The pain is usually either in the epigastrium or right hypochondrium. Agree. Second thing, acute in
Radiating to
onset.
the yes, sir. Radiating to the right shoulder.
It may radiate. It never expect it to radiate in 10% of cases. It may radiate to the inferior angloscapular or right shoulder region or interscapular region. These are the usual places where it may get radiated. Okay. Usually moderate to severe pain and very often necessitating injections or analgesics. Okay. It may be associated with vomiting. Then other associated symptom, if there is cholangitis which has settled in, there may be fever, chills or rigor. Okay. Then gradually over the next couple of days, the patient may have darkening of the jaundice followed by itching and other things.
Yes.
So each description has to be, you have to have clarity of concept of each of the problem. So is the pain characteristic of a biliary pain in this case?
No, it's a diffuse kind of pain.
Yeah, it's a diffuse kind of pain. With any stretch of imagination, we cannot bring in biliary. We cannot bring in biliary. Suppose you want to bring in hepatobiliary, what is the only option now left? You're dull aching severe pain. The patient felt all over the abdomen, but if it is hepatic outflow obstruction or something like that to produce severe congestion and pain, it should still be in the upper abdomen. No, liver pain is not felt in the entire lobe diffusely.
Yes.
So there is some problem here. We are not able to explain, bring in the jaundice probably as the cause or something related to the etiology of pain. Pain has to be therefore independent. That's what I feel. Okay. So these are no negative history. I think this patient has got a very complicated past history, which makes it more complicated than abdominal pain. Okay. Aron, please read it out.
Yes. Sir, my patient is a known
I
case
would have
of chronic.
expected to present a less historic patient and more concentrating on the pain part, because now we get digress on his liver part, no? Okay, probably I would short it saying that it's a known case of hemochromatosis diagnosed since 2015, and he had undergone endoscopy with small varices, etc. So it's a known case of hemochromatosis with on phlebotomy, and it was diagnosed about 4 or 5 years back. The background is okay. That much only, no?
Yes. And
okay. And it's a non-case of Parkinsonism, non-case of hypothyroidism, right inguinal hernia repair, history of cam intake for skin disease. Last intake was 5 months back. Okay. So do you think this cam intake is relevant in the present context?
no, sir, actually he is absent for the last, he didn't take for the last 5 months according to history.
So what is the usual cutoff period for a drug intake history to be considered?
3 months, 90.
Yeah, 90 days is the standard. Okay. So that probably is not relevant. Right inguinal hernia repair is there unless, of course, he had developed recurrence of it and then created some confusion. We do not know. We have to look. Therefore, this history there, you have to look at inguinal region very carefully. So do you think this past history of hemochromatosis, Parkinsonism and hypothyroidism is relevant in this case?
No, sir.
Sir,
You have to say yes or no.
No, sir.
Okay. Okay. Okay, I think
No,
we will
what
come
was
to
that?
somewhere.
What was the history of that HFE and all that? Can we
Pardon?
go back? Hemochromatosis? Proven,
Yeah.
no? Proven, no? She says
It's
all
a
this.
known
no?
case of chronic liver disease,
So
hemochromatosis.
how will you present this case? Then you have to say patient is a known case and diagnosed as a case of hemochromatosis, and now she's come with pain. Then the whole thing goes towards hepatocellular carcinoma and things like that. You have to mention about the loss of weight, loss of appetite, because then you're getting a clue from that history, no, that she's a known case of hemochromatosis. Because you've got the gene, this thing that is positive. Varices are there. So you cannot, in this patient, we cannot start discussing of the abdominal pain and jaundice. You have to say she's a known case of chronic liver disease from 2016, complaints of abdominal pain and jaundice now and diagnosed earlier. You have to give that. This is what happens in all corporate sectors. We are not here to find out what's the cause of. She's a known case of hemochromatosis based on, and she's a chronic liver disease patient. In this background, she's developed an abdominal pain. Now my focus is hemochromatosis is a risk factor for HCC. My whole focus will go towards loss of weight, loss of appetite, paraneoplastic manifestations of HCC. It will get directed towards that. That pain has got nothing to do with this.
So after hearing this story, Vishwas, do you want to change the diagnosis? Now there is a strong past history of, not the current history, not past history. There's a history of liver disease. Another thing, Aron, as Madam rightly said, see this part of this, if you present it like that, see, we were all discussing about the confusion regarding all these things.
pain.
Yeah.
Now, once you have told us that this is a known case of chronic liver disease, because you also is not finding it yourself. The patient is telling you all these things. Okay, so that information should be available to you and us at the same time. And then that's the foundation or the denominator on which we start our case. The known case of hemochromatosis, chronic liver disease like this, and now presented with abdominal pain and jaundice. Okay, now the dimensions completely, I mean, the scenario completely changes.
Exactly.
Okay.
Exactly.
So now if it is a known case of chronic liver disease, now present with abdominal pain and jaundice, how will you discuss?
other thing is that you have to say the diagnosis of hemochromatosis, chronic liver disease, has been based on genetic study and with repeated phlebotomies for the past 4 years or 3 to 4 sessions. So that substantiate, or with the liver biopsy, substantiate that, because it may be hemochromatosis, it may be hemosiderosis, it may be anything. So you have to substantiate that. When we say no case of Crohn's colitis or whatever it is, we'll say based on colonoscopy, endoscopy, colonoscopic and histological, and on treatment. Then that tells us we are justified in giving a firm diagnosis. If you are doubtful about that, then you mention about any history of decompensation, 5
No,
years
ma'am.
history.
No, ma'am. Till now, he never.
So in your first history, when you went jaundice, you mentioned about decompensation. I was wondering why you're talking of abdominal distension there in that case. So what you have to do is, the whole case. This is exactly, if you go to Hinduja Hospital or you go to any of these corporate hospitals, you'll get this worked up cases. And in that context, now you have to discuss what is the cause of diffuse pain in this patient. Is it just an adhesive colon? And what's the cause of jaundice? That's all that we need to know. And then say she's a known case, or no, he or she's a known case and is on follow-up. So chronic liver disease and portal hypertension is confirmed in this patient, right?
Yes, ma'am. Yes.
Now see, look at your summary. Your summary has got nothing to do with the pain.
Where is Sanjay? Sanjay.
I'm here, sir.
Sanjay, where are you? Please switch on your
Yes, sir.
video.
I'm here, sir.
I am not seeing you, but
BT, someone's this thing is
yeah, let me find out who is in the side. So I will find out.
that honor 7x has to mute.
Please accept the active discussants and the presenter and the faculty. All others, please switch off your audio. All others, please switch off your audio. Okay. Sanjay.
Yes, sir.
Sanjay. Okay.
Yes, sir.
Now you summarize and tell us.
68-year-old.
You heard already where we have to modify, etc. Don't just read it out. You have to tell it from your memory.
68-year-old male, known case of cirrhosis, probably hemochromatosis, presented with abdominal pain since 2 weeks and progressive jaundice since 4 days. With,
1 minute. Hemochromatosis is not cirrhosis, okay?
yes. Yes, madam.
Hemochromatosis is not cirrhosis. He's just a chronic liver disease. I don't think he's decompensated. So he's just a chronic liver disease. Patient
Chronic
is a
liver
case
disease.
of hemochromatosis, bring it straight, with features of portal hypertension, right? That's all. It's a known case of hemochromatosis on treatment requiring repeated phlebotomy with history or with evidence of portal hypertension based on whatever he said that he's had varices and banding and all that. And then compensated and then summarize. Now tell us about the jaundice and summarize the jaundice and the pain.
Abdominal pain is a insidious and onset progressive dragging type of pain that was
Don't describe the pain again. We have heard enough of it. Half an hour we've been discussing only pain and jaundice. Summarize it.
abdominal pain since 2 weeks and progressive jaundice since 4 days with no cholestatic symptoms or cholangitis.
So what is your diagnosis?
Patient being a known case of cirrhosis, most probable diagnosis will be HCC.
1 minute, you have to mention non-bleeder. Important things you have to mention: non-bleeder,
Non-bleeder, no.
non-bleeder with no altered sensorium. You have to mention. You have to mention all that with no evidence of decompensation during any stage. But what is missing in this history? Anorexia, nausea, anorexia, weight
Loss of weight and loss of weight and loss of
manifestations. Nothing has been mentioned.
Yes, ma'am.
Okay, therefore you think it is? Your first diagnosis is?
And include all the comorbids. There are about 5 comorbids in this patient. In your summary, you have to mention that. You have to mention that. You have to mention that. You have to mention, is he a teetotaler? You have to mention that. In the summary, we have to suppose he was not listening to the history. I must put everything when you're summarizing.
We have to include the entire thing, like Parkinsonism and hypothyroidism are active diseases for him, no? So that also will have to become. That also will have to be mentioned.
What's a skin disease?
Ma'am,
What about the diabetes?
Aron, what is the skin disease for which you are taking camp?
He had some discoloration with ulcers over there.
Is it a he or a she? First,
We
let
don't
us
know
know
the
that.
diagnosis.
He
Then all the time you're changing the gender. He, she, she.
he-
So patient is a he. Okay,
he-
male patient, right. So what is the skin condition that can get in hemochromatosis that requires treatment?
Ma'am, because of
Is
the
hemochromatosis associated with any skin lesion?
hyperpigmentation, melanin.
Yeah, that's what. So maybe that's why she's
Hemochromatosis.
got that. So he's got bronze. Does he have diabetes? Most important, bronze diabetes. That's what you first mentioned.
No, diabetic.
Yeah, all that you have to mention. Those are the characteristic features, no? Any, and was liver biopsy done for confirmation?
No.
All that you have to mention, unconfirmed. It's only heterozygous. We do not know whether it is true hemochromatosis or not.
Yes, ma'am.
In their summary, all this has to come surface so that we know what we're dealing.
Okay. Any other? See, for one you told about hepatocellular carcinoma. Okay. Dull continuous pain can occur. Second, any other possibility? What are the other situations in the liver where the liver can produce pain? What is the cause of pain actually in hepatocellular carcinoma?
B and C virus.
Superimposed capsular retraction.
Hmm?
Capsular retraction. If the tumor
Is liver that very pain sensitive organ?
no, sir.
No. So how does it produce pain? What are the causes of pain in a hepatocellular carcinoma?
Large mass. I mean, if it
Okay,
is a
large
mass
mass effect is stretching of the liver capsule. Agreed. Okay. Have you heard of what is the auscultatory? What are the auscultatory findings you may get in HCC? One is bruit. Anything else?
Bruit.
You can get a rub as well.
Rub.
There could be a sort of some sort of an inflammatory reaction on the surface of the liver, which will irritate the parietal peritoneum. Okay, so one can get a rub, and also pain also can be due to that. There could be distension of the liver due to additional hepatic outflow obstruction in a patient with the HCC. Even by itself, the outflow obstruction can produce acute distension of the liver, stretching of the capsule, and pain.
IVC, compressing the
Dull-making pain, upper abdominal pain can be due to stretching of the liver capsule due to acute increase in size of the liver due to outflow obstruction, acute hepatitis, liver abscess, probably bleeding into HCC. So many things can have. Okay.
Yes, sir.
And in acute venous congestion due to cardiac problems also this may occur occasionally. Okay, we will go through the findings. Aron has mentioned acute decompensation secondary. What do you mean by that?
Sir, he never had any past history of decompensation, sir. This is the first episode of decompensation in the form of jaundice.
But can you say it is decompensation?
Um,
What are the other signs of evidence of decompensation? We haven't examined the patient. Okay, fine. HVOT, viral hepatitis, sepsis, DILI, extra. I think you cannot mention the entire possible causes of hepatobiliary diseases in a differential diagnosis. That's also important. You have to select out few, and it should be according to the most likely possibility. The first one should have maximum points in favor and least points against, and probably the last one should have probably lesser points in favor. But you cannot mention the entire hepatobiliary diseases in a differential diagnosis. Understand? Because if you put a list like that, what does you gain? You have mentioned the entire list, no? We actually expect you to make a judicious decision making, not a full list of possible things. Okay. So this decision making is what is actually assessed in the examination. Your ability to narrow down the list and tell few important diagnoses. That is what is assessed. This is the most important critical step in your examination. That is telling the list of differential diagnoses and defending it. Okay. So practice it, practice it, practice it. Because this is the most important thing which is considered in all examination.
BT,
Yeah.
he has to tell us why did he consider extrahepatic in this patient. He's
Yeah.
taking both. Now tell us why
That's
did
why,
he
sir,
consider.
he has mentioned all the possible hepatobiliary diseases in this. That should not be the way. So, how would you explain abdominal pain if it is in if it's a delay?
So sepsis.
Delay is basically a parenchymal or a cholestatic disease, no? How do you explain abdominal pain? Very rarely they may have some dull aching pain due to the maybe sort of inflammatory process. Extrahepatic. What do you mean by extrahepatic? Again, it's incomplete. What extrahepatic it is? Is it extrahepatic portal venous obstruction or extrahepatic biliary obstruction? What do you meant?
Sir, choledocholithiasis and Mercy's.
So you have to be highly specific. You have already mentioned choledocholithiasis, Mercy's syndrome, and tumor, cholangiocarcinoma. All of them are extrahepatic, or is it a heading?
Heading, sir. Heading.
Okay, heading. Okay. Choledocholithiasis, Mercy's syndrome, tumor. What do you mean by tumor?
HCC and colon heading, sir.
Oh, this is a subheading. Okay. HCC and cholangiocarcinoma. Okay. I think heading and subheading should look like that also. Okay.
For hemochromatosis, everything is there. Except for hemochromatosis, all the diagnosis.
Okay. Now that you mentioned extrahepatic, what is there in this case to suggest extrahepatic?
Sir, actually, sudden onset of.
We would not have asked you this question if you have not mentioned it. Whatever you mentioned, you have to explain.
Sudden onset of pain and jaundice, only a short duration history is there, sir. That's why.
Fairly acute onset of pain followed by jaundice, but not typical features of cholestasis. Can you explain it? Do you expect features of cholestasis in all patients with the extrahepatic biliary obstruction, especially choledocholithiasis?
No, sir.
Yes or no? Vishwas? That's your answer. Sanjay? We are not hearing.
Sir, question, can you please repeat the question, sir?
Okay, you have to listen to all my question as well. Okay. So, is it possible for a person with the choledocholithiasis not to have features of cholestasis?
Switch on your video. Want to see, please. Switch on your video and speak.
Okay, as you are not answering, I will tell you. See, in choledocholithiasis, unlike in tumor causing extrahepatic biliary obstruction, the obstruction is fairly incomplete. Okay, in tumor, gradually the tumor blocks it and it becomes complete. Okay, sort of irreversible. But in choledocholithiasis, the stone moves. The bile duct may dilate and readjust its size, and the bile may flow along the sides of the stone. That is why, as it's not a complete block, they have got a high vulnerability to develop cholangitis also. The gallbladder also may be infected earlier due to cholecystitis. So it's a partial obstruction. So typical cholestatic features may not be there in all cases of choledocholithiasis. Maybe 30 to 35 may not present like. What is Mercy syndrome?
Stone in the cystic duct, sir.
Pardon?
Stone obstructing the cystic duct.
Okay, and therefore?
Type 1 malignancy.
And then? Okay, cystic duct, there is a stone. Agreed.
Yes.
How does it produce jaundice?
Obstruct the outflow of the.
So just a stone sitting at the cystic duct, how can it produce bile duct obstruction? Because if there is no bile duct obstruction, see, stone sitting at the cystic duct produces actually distension of the gallbladder, acute cholecystitis or biliary pain, no?
Yes, sir.
How does it produce Mercy syndrome? What is Mercy syndrome? Aron?
So, it's a external compression of the common hepatic duct or the common bile duct.
Yeah, this stone with the cystic duct in that particular area is compressing on the okay, bile duct. That is why it is producing jaundice.
Yes.
Okay. Ma'am, can we proceed?
This viral
So we have to
hepatitis.
have.
In viral hepatitis, what are you thinking?
Ma'am, reactivation of acute hepatitis B or hepatitis E.
E.
Acute hepatitis E or reactivation of.
In the discussion itself, we told you, know, of course, this you have written earlier, the clinical history is not typical of a viral hepatitis.
Prodromal, yes.
Okay. So probably this is your first presentation. So you would have put the entire list, but I think in subsequent presentation, you have to be careful. Things which are very unlikely from the history should not come anywhere near the differential diagnosis. That's it. Because if you put it blindly and try to defend, you will not reach anywhere. Your time will be lost. Okay. So we don't want you to unnecessarily spend time on defending things which are very unlikely.
Please include all the comorbids. Comorbids are the most important because you have to manage that and the jaundice and the hepatomegaly. So even when you're mentioning the differential diagnosis, you have to include this thing.
Okay, I will run through it. So icterus pleasant and okay. Inspection, not much of finding, no hernia. Shifting dullness present.
No tenderness. No tenderness.
Non-tender abdomen. Shifting dullness present. Was there a rebound tenderness?
No, no.
No. In a patient with the diffuse pain, we considered peritoneal disease also. No? You should have mentioned no rebound tenderness negative specifically.
Okay. Just 1 second. Dr. Thomas, when you're typing this, after palpation, you have to give a second indent, so that the soft goes inside. You cannot write like this. This is not the way to present. Palpation, you give an indent. Non-tender, move it in. Spleen, move it in.
Okay.
We're not having difficulty in getting your headings. You have to search the headings in your text. What about the liver? What has happened to the liver? What's the liver span?
Liver span was only 10 centimeter, ma'am. Liver is not palpable.
Is it mentioned?
You have not mentioned anything about
it has to be mentioned. It's very important, no?
You have not mentioned anything about the liver and the gallbladder.
Is gallbladder palpable?
No.
Because it was in your differential diagnosis, no? See, now the problem begins. All the things which you have mentioned specifically in your list of different diagnoses have to be excluded or confirmed on physical examination. So, positive findings and relevant negative according to your differential diagnosis must be here. Okay.
What about the superficial veins?
Not visible.
Nothing is mentioned here.
Superficial veins, back veins, so many things have to be mentioned. Okay. So there are many things to this particular part. There's a lot of need for improvement. Okay. Now, without digressing much time, we will ask you: did you investigate and find out the cause?
Wait 1 minute. Cardiovascular system. What will you examine in this patient?
Ma'am, actually, heart failure is the one to rule out, ma'am. Any raised JP or S3.
You have to specify that, doctor. You have to mention it.
Why Aron heart failure, Ando?
Sir, hemochromatosis. Iron deposition in the.
Okay, agreed. But even otherwise, any cirrhotic for that matter, there could be cirrhotic cardiomyopathy. Okay, yes. Especially the most common cause being non-alcoholic fatty liver disease, alcoholic fatty liver disease. Both can produce cirrhotic sort of problem. Alcohol can produce alcoholic cardiomyopathy. Non-alcoholic can produce just cirrhotic cardiomyopathy. Hemochromatosis can again produce cardiomyopathy. Okay. So examination of the heart and looking for features of congestive heart failure would be important, and especially in this case, because of dull aching pain and all, we were suspecting whether there's a outflow obstruction or severe venous congestion of the liver, no?
Yes.
So now you got...
What about the testicular changes in hemochromatosis?
Ma'am, actually, hypogonadism is one of them.
All that, doctor, you have to mention, doctor. Everything has to mention. How do you identify hypogonadism?
Testicular atrophy.
Some time back. How will you diagnose hypogonadism?
The general examination didn't mention anything.
Very sad history and sad.
Okay, Aron. So see, this was a case of abdominal pain. Probably you concentrated on that. But remember, whether it is abdominal pain or jaundice, a physical examination description has to be complete. Okay. Whether it is general examination, examination of the abdomen, inspection, palpation, all those things will have to be perfect, because a mistake committed by a DM or DNB student in the examination on physical examination will not be tolerated by any examiner whatsoever. Okay. History is something which is variable. Okay. But physical examination is something which cannot change. If that's a physical finding, it has to be there. Okay. Therefore, positive, statistically positive general examination finding, specific negative general examination finding, and positive abdominal and other systems. Okay. And relevant negative. So it must be always there. And you, okay. From once you start presenting, you definitely will improve. So we will. So what was your diagnosis?
So,
Cut it short, because we have to finish your
yes.
approach to abdominal pain. So ascitic
Yes,
fluid
yes.
shot 1000 cells with a 95% neutrophil. So it was SBP.
Yes, miss.
Are there anything inside the liver?
No, sir. Actually,
MRI
only
shot
CLD.
gross
Only
polylithiasis. Okay. So that is, the stone is in the gallbladder. So it doesn't explain the jaundice part of it. So how do you explain the jaundice part then?
Sepsis.
How do you explain the jaundice then? SBP, just like that, within a week, producing such high degree of jaundice is usually unusual, unless you are completely off the track and missed it and patient develops septicemia. This is very unlikely.
Delay if the patient denies or
Delay, but you said the patient are not taken any new drug for the last
yes,
90 days.
Yes. Patient.
And the transaminase elevation is also, very mild. So I think there are unanswered questions here. Why this patient developed jaundice? That remained unanswered.
Viral profile.
Negative, ma'am. Viral negative.
What all did you do?
ABC.
ABC.
ABCE.
What markers would you do for B, doctor?
Core antibody we did, ma'am. IgM core antibody we did.
Did you do an HCV RNA and HBV DNA?
Quantitative PCR we didn't do.
You have to do an HCV RNA, no? You don't have, everything is negative. Your SGOT, SGPT is all near normal. What was the LDH?
LDH was 220.
It's not shown here.
Serum LDH.
So what is your comment on the LFT? Shetty, Dr. Shetty.
Yes, ma'am. Predominantly direct hyperbilirubinemia with the hypoalbuminemia and normal enzymes.
Not normal. SGOT is 1
SGOT is really elevated.
What's your comment on the transferrin saturation index?
That is very more than 45%. It's quite high, madam. It is
so
high.
What's your comment? What's your comment?
No, it fits into the picture of hemochromatosis.
It fulfills, no? Ferritin is also elevated. So there is something there. So you have to now, we need an imaging. Move to an imaging. What was the ultrasound report? What was the ultrasound
Aron,
report?
do you remember the ultrasound report?
Ultrasound showed only ascites and CLD and splenomegaly. So we did an MR.
Okay, so it's basically cirrhosis liver. You're not,
Yes.
neither pain is there, because even when the tenderness was not there on examination, you cannot bring that in the history, doctor, because you brought the VAS score right up to 6/7. There's no tenderness on examination. How can you present that as a symptom when you're getting nothing on examination? Jaundice is fine. It is part of end-stage liver disease. Ascites is there, everything is there. It's part of terminal stages of, and HCC has to be ruled out. You need a second imaging. Okay, move on. So then we can discuss abdominal pain. Move
Okay.
on. Next.
So, for all the other person who are going to present in future, would expect
So-
you to concentrate mainly on the dominant symptom which you are going to present, so that the discussion will be much more useful. But otherwise, we'll digress to other symptomatology. Like for example, we actually have a class on jaundice in coming the next couple of weeks, so we could have discussed all those parts later. So, concentrate on the major symptom. Don't take cases with too many complications, so that we will lose our time in those. Okay, now Dr. Aaron, you can.
BT,
Do you
just
have
one
your,
second. BT,
do you
just
have your
one second.
slides?
BT, the patient has got a moderate ascites, and then even when you see the case, you can ask directly. And you cannot say there's no abdominal distension, okay? There's a moderate ascites there. So be very careful. As BT said, please take straightforward cases, straightforward, so that you don't have too many complications, because you're not able to analyze and put all the three together, okay? We move on to the abdominal pain. Yeah, move on.
Do you have the slides, Aaron?
Sir,
The slides are with you, no?
yes, sir.
Okay, you can upload and start presenting.
Sir, I'm not able to share my slides.
Is it on your desktop?
Yes, sir.
Then start sharing, you will see the desktop.
Sir, can you see the slides, sir?
No, you have to upload. You can double click on it and it's coming. Yeah. Now you put on the usual slideshow mode.
Yes. So can
Oh,
you
good.
see?
Okay, now you start.
So abdominal pain, the surface anatomy can be described. It is divided into 9 regions by 2 vertical and 2 horizontal imaginary planes. 2 lateral vertical plane pass from the femoral artery below to the costal margin close to the tip of the 9 costal cartilage. 2 horizontal planes pass across the abdomen to connect the lowest point of the costal margin and tubercles of iliac crest. It is divided into 4 quadrants by a single vertical and horizontal imaginary planes. These regions and quadrants are of clinical importance when examining and describing the pathologies related to abdomen. So,
Can you, 1 minute. How do you get the vertical line, doctor? No one palpates the femoral artery, okay? It's a mid-inguinal point.
okay,
It's not a mid-clavicular, it's mid-inguinal point, and then move it upwards. Yeah.
So abdomen is divided into right hypochondrium, epigastrium, and left hypochondrium, right lumbar, umbilical, and left lumbar, right iliac, hypogastrium, and left iliac. It is again divided into right upper quadrant or left upper quadrant, right lower quadrant or the left lower quadrant. Pain is defined as an unpleasant sensory and emotional expression associated with an actual or potential tissue damage. It can be explained by a peripheral mechanism or by a central mechanism. The nociceptor or transduction. Painful stimuli are detected by nociceptor, which are free nerve endings located in tissue organs. They have high thresholds and under normal circumstances only respond to nauseous stimuli. There are 2 distinct types of nociceptor. High threshold mechanoreceptor stimulated myelinated A delta fibers and transmit well localized sharp pain that lasts as long as the stimulus. Polymotor nociceptor stimulate an unmyelinated slowly conducting C fibers which responds to mechanical, thermal, and chemical stimuli, example hydrogen, potassium, bradykinin, serotonin, ATP, and prostaglandins. Conduction. A delta fibers are fast conducting and transmit sharp pain till stimulus is present. C fibers transmit a less well-localized persistent aching pain that persists even after the initial stimulus are gone. C fibers express several presynaptic receptors that modulate the transmitter release. These include cholecystokinin, opioids, GABA B receptors. A beta fibers conduct low-intensity mechanical stimuli which convey touch and not pain. However, in chronic pain status, they are involved in transmission of pain also. The ascending system. The spinothalamic tract carries a sensation of contralateral sides and terminates in the somatosensory cortex, where pain is perceived and localized. Spinoreticcular tract, it terminates in pons, medulla, and periaqueductal through reticular formation. It is involved in descending inhibition of pain. Spinomesencephalic tract involves in the modulation of descending colon, descending control. Descending control, the dorsal horn receives input from higher centers that modulates the response to nociceptor input. Inhibitory tracts descend from the brainstem and synapse in the dorsal horn. The key neurotransmitter involves the noradrenaline 5-hydroxytryptamine and endogenous opioids. Factors for poor localization of visceral pain, the cause are splenic afferent spreads across the broad range of dorsal root ganglion. Spinal afferent have bilateral generalized and overlapping visceral distribution. The overlap between visceral afferent and somatic pain neurons in the dorsal horn. The visceral pain causes stimulation of visceral spinal nerves, described as crampy, colicky type of pain, tends to diffuse and difficult for a patient to pinpoint, commonly seen with other signs and symptoms such as sweats, vomiting, nausea, and tachycardia. So the pain, it is the localization of visceral pain. It is mainly divided into three. That is in the epigastrium, mid-abdomen, and the hypogastric region. The epigastric region, mainly the causative organs will be the liver, the gastroduodenal, whereas in the mid-abdomen, it is mainly the jejunal-ileal structure, the small intestine, and the ileocecal junction and the ascending colon. Whereas in the hypogastric, it is mainly the transverse colon and the descending colon and the rectosigmoid and the pelvic structures.
So embryologically, upper abdominal pain is structures arising from the foregut.
Foregut, midgut, and hindgut.
Central abdominal pain is midgut, and lower abdominal pain is usually from structures arising from the hindgut. Okay. If you remember that, things will be easier.
Yes, sir.
Continue, please.
Somatic pain, a focal pain that occurs when nerve fibers within the peritoneum are irritated by a chemical or a bacterial inflammation. More localized and usually described as sharp, constant murmur worse by coughing or movement. Referred pain, radiating pain that is felt at a location away from the point of origin, poorly localized, dull aching sensation, example acute cholecystitis, pancreatitis, and renal stones pain, etc. So any pain, the approach should be first, any acute abdominal pain, the first approach should be airway, breathing, and circulation to be examined and make sure it's maintained, and history taking, examination, blood investigation, radiological investigation. Coming to the history taking, for pain, the site has to be evaluated, the onset, the character of the pain, radiation, associated symptoms, timing, the exacerbating and relieving factors, and the severity of the pain. If pain is experienced mostly in the upper abdomen, think of perforation of a gastricoduodenal ulcer, cholecystitis, or a pancreatitis. If pain is located in the mid-abdomen, disease of the small bowel is likely. Pain in the right iliac fossa is commonly due to appendicitis. Pain in the left iliac fossa is due to diverticulitis.
So you are mentioning about acute abdomen.
Acute abdomen pain.
Yeah, the diagnosis differs for acute abdomen and for a chronic abdomen. So one has to be very clear about acute abdomen. You have a set of diagnosis. Chronic abdominal pain, you have a set of different diagnosis for the same region. Okay. Continue, please.
If pain radiates from the right subcostal region to shoulder or to the interscapular region, inflammation of the gallbladder, cholecystitis is likely the diagnosis. If pain begins in the loin, but then is felt in the lumbar region, a renal stone, a renal infection should be considered. Pain beginning in the loin and radiating to groin is likely to be due to a ureteric calculus, and umbilical pain radiating to the right iliac fossa is usually due to appendicitis. Central upper abdomen pain later radiating.
Can you explain why the umbilical pain, the particular pain begins in the periumbilical and subsequently it is felt in the right iliac fossa? What is the explanation?
Sir, initially the peritoneum, the the inflammation of the appendix won't be there in the initial. So there'll be
30. Okay, the initial part is the typical midgut pain. Appendix belongs to the midgut.
yes.
Okay, the initial part. Once there is a peritoneal inflammation which sets in on the serosa of the appendix, the parietal peritoneum get irritated in the right iliac fossa. There will be other changes of inflammation. So many things, the moment everything will come together, and the parietal peritoneum, when it get irritated and inflamed, the pain get localized to the right iliac fossa. Okay. Next.
So constant severe pain felt over many hours is likely due to infection. Colicky pain, on other hand, that is pain lasting for few seconds or minutes, then passing off, leaving the patient free of pain for a further few minutes, is typical of small bowel obstruction. If such pain is suddenly relieved after a period of several hours of severe pain, perforation of viscera should be considered. So, differential diagnosis of abdominal pain depends upon the locations. The right upper quadrant pain is mainly because of cholecystitis, cholangitis, pancreatitis, then other conditions like pneumonia, pleurisy, subdiaphragmatic abscess, hepatitis, or Budd-Chiari syndrome. And epigastric pain is mainly because of peptic ulcer disease, gastritis, GERD, pancreatitis, myocardial infarction, pericarditis, ruptured aortic aneurysm, or esophagitis. Left upper quadrant pain, there will be splenic infarct, splenic rupture, splenic abscess, gastritis, gastric ulcer, pancreatitis, or a subdiaphragmatic abscess.
Now, please
The right-
don't include all that, okay? Gastritis, gastric ulcer, and all in left upper quadrant. This is all textbook description.
Okay.
Please
Okay.
don't include. Yes, be practical. Be practical. You have the table with you, but have a practical approach to it.
Yes, ma'am.
Will you
Yes.
consider aseptic disease if the patient is left upper quadrant pain?
No,
Only
ma'am,
there's
no.
a situs
Mainly of
inversus.
splenic in.
Only when there's a situs inversus, you'll get that. So even though you have a list of the whole thing, just be careful in what you're writing. Okay, you cannot. This is what the problem is. Where if you have typed it, you have got the right this thing. Because you've not typed it, you just cut and pasted it. You yourself do not know what's happening. Continue. Be very careful.
Yes. So right lower quadrant pain, it is mainly because of appendicitis, salpingitis, and inguinal hernia, and ectopic pregnancies and nephrolithiasis, and IBD. Periumbilical is early appendicitis, bowel obstruction, or ruptured aortic aneurysm. And left lower quadrant is mainly diverticulitis, again inguinal hernia, ectopic pregnancy, and nephrolithiasis. The cause.
But
And
irritable bowel is a chronic condition, no?
yes.
Okay.
So physical
Continue.
examination. Physical examination. So
You've not included lead poison. You've not included all porphyria. These are all those pains that will have no findings. There'll be no localization. These are all causes of abdominal pain.
What are the causes of abdominal pain due to metabolic conditions?
Metabolic conditions and abdominal pain.
hypercalcemia,
Okay, hypercalcemia, agreed. Most common in the community?
Hyperlipidemia.
No, diabetic ketosis. Okay, diabetes,
Yes.
number one. Okay, then? Okay, diabetes mellitus, hypercalcemia, hyperlipidemia. Okay, that produces pancreatitis, not pain otherwise. Okay, what are the other systemic conditions which will produce abdominal pain without any specific pathological
Porphyria.
finding in the GI tract?
Congestive cardiac.
Pardon? In children, especially in olden days,
Porphyria.
porphyria.
Like,
Somebody is using two devices. Please switch off the second device because echo is generally due to the second device. Now there are only two people, three people with the audio on, myself, Aron, and Vishwas. If anyone having a second device, please switch off. Okay, porphyria, agreed. Lead poisoning, okay. And another condition, henoxolane purpura. The abdominal findings may be very minimal, but abdominal pain may be extremely severe. You may not find any CT finding or anything. It may be only history or some rashes on the thighs. Okay.
Abdominal
This-
migraine.
Yeah, the other condition like abdominal migraine can present with recurrent abdominal pain. So there are other conditions where the abdominal
Familial
findings
Mediterranean
may be very little. The pathology may be practically missing from the GI tract, but patient may present with abdominal pain. In olden days, people used to describe about neuropathy conditions also producing abdominal pain.
Herpes zoster. Herpes zoster.
Yeah, herpes, very interesting. Yes, herpes can present with abdominal pain. Very interesting. Sometimes you may even completely miss it unless you don't examine the patient properly.
Sir.
I had a situation, I will just mention. I had a patient who came to me with pain, right hypochondrium, and I asked for an ultrasound scan, and ultrasound was negative, and patient came 2 days later and told me, in fact, he told me over the phone that I have some allergy to that gel used by the doctor, and what shall I do? Okay, I said, I will take some medicine, etc. And 3 days later, he again told, this is not, this is, I have some rashes sort of thing, vesicles and all has come. Then only I realized that, okay, it's abdominal pain which occurred much days earlier before the rash occurred, and the patient misdiagnosed the rash as allergy. Okay, so this came later. Sometimes if you don't address the patient properly, we may miss it completely. Herpes, that's a good point. Continue, Aron.
Physical. So, patient who is lying still in the bed in the fetal position and reluctant to move or speak with a distressed facial expression likely to have peritonitis. Before concluding that an abdomen is silent, the examiner should listen for at least 2 minutes and in more than one quadrant of the abdomen. Pelvic organ and external genitalia should be examined in every patient with acute abdominal pain. Gynecological pathology should be excluded in all women with acute abdominal pain. Blood investigation should include.
Tell specific points. See, in a patient with acute abdomen, you have to be gentle. Most of us, being the medical gastroenterology, we may not be called to the ED for managing acute abdominal pain. But once you pass out, actually, you will have the responsibility because they will refer the patient to you. So when you examine the patient, you have to be careful. Don't just and poke your finger onto the abdomen. You talk to the patient, touch the abdomen gently, ask the patient where is the pain maximum, or if possible, ask the patient to show you where is the pain maximum felt by the patient. Okay. Then you have to do a superficial palpation. Then only a deeper palpation. Don't try to elicit right iliacosa tenderness or McBurney's tenderness or no, those sort of things by vigorously pressing, because once the patient gets severe pain, they will keep the abdomen rigid and you won't be able to palpate or get any finding whatsoever afterwards. Okay, so first find out the site of the pain, maximum site of pain from the patient by ask the patient to press, and then you do all the examination around and finally come to the area if you really want to press hard and elicit some sign. Okay. Yes. And another thing, don't just finish on abdomen. You have to look at other systems because pleurisy, understand, pericardial disease, diaphragmatic disease, all those things we have to look at because the examination of the chest is important, examination of the heart is important, examination of the spine is important. All those things are also important. Okay, just don't stop with abdomen. Okay.
So how to approach an acute abdominal pain? So if the patient is in shock or hemodynamic instability, then urgent resuscitation and urgent surgical evaluation should be considered for laparotomy. The DDs will be perforated viscous, severe pancreatitis, rupture spleen, or rupture abdominal aortic aneurysm. If there is no patient is clinically stable, if the pain is in the right lower quadrant, then consider for Alvarado score. So Alvarado score is more than 5. It is more suggestive of an appendicitis. And an imaging will give the clue of appendicitis.
Which imaging? Which imaging? You have
Sir,
to speak. Imaging can be plain X-ray, abdominal, ultrasound, CT, MRI.
CT, appendix protocol CT is the imaging
Why
choice.
don't you do the ultrasound?
Sir, most of them if the appendix in the
Yeah, in acute appendicitis, ultrasound has got a less pickup rate and you may miss it completely. So a CT would be ideal. Agreed. Unless you have an extremely high resolution ultrasound and a highly experienced sonologist, most of the acute appendicitis are missed. I would say large 60-70% is missed. Only 30% is usually diagnosed by ultrasound.
If the
Yes.
if it is a gradual right upper quadrant pain, it is a postprandial discomfort, then ultrasound imaging will give the clues of cholelithiasis, cholecystitis, or bile duct obstruction, or cholangitis.
Okay,
It is
so
not
in a severe pain, the protocol is actually plain X-ray abdomen erect to look for perforation or dilated bowel loops, ultrasound abdomen. If there is nothing found out on ultrasound, immediately CT. That's the usual protocol in most of the hospitals. Okay. Okay, go ahead.
If nausea, vomiting, obstipation, or constipation, abdominal distension, prior abdominal surgeries, then an upright abdominal filling, rule out small bowel obstruction, and then consult for CT. If a sudden onset diffuse pain involving guarding, rebound tenderness, peritonitis, upright abdominal pain, to look for perforated viscous, diverticulitis, or mesenteric infection, and acute pancreatitis by getting a CT scan. So come to the individual disease, acute appendicitis. Here the it will be present with the predominant symptoms of anorexia, nausea, low-grade fever, and vague periumbilical pain. Then the pain migrates to the right lower quadrant within 6 to 8 hours due to peritoneal involvement. So the Alvado score, which will have migration, anorexia, nausea, tenderness, and rebound tenderness, elevated temperature, leukocytosis, and left WBC shift. If a score of less than 5 excludes the appendicitis, if a score of 5 to 6 suggestive, and a score of 9 to 10 is likely to be acute appendicitis. So an appendix diameter greater than 10 millimeters is generally considered to be diagnostic of appendicitis, and CT signs of acute appendicitis include the periappendicular fat inflammation, presence of fluid in the right lower quadrant, and failure of contrast dye to fill the appendix. So come to the acute biliary disease. We have the acute biliary pain. It's a syndrome of right upper quadrant or epigastric pain, usually postprandial. It is caused by transient obstruction of cystic duct by gallstone and self-limited and lasts for less than 6 hours. If persists for more than 6 hours, it is polycystitis. It's a dull aching pain and can radiate to lower endoscapula. Associated with nausea, vomiting, and low-grade fever, and have Murphy's sign. That is
What is Murphy's sign?
So we ask we'll palpate for the gallbladder and we'll ask the patient to take a deep breath.
For gallbladder.
So palpate in the right
in every patient with the biliary colic, you palpate the gallbladder?
No, sir. We'll palpate in the right hypochondrial regions.
Okay, Shetty. What is Murphy's sign?
Pain.
Pardon?
On deep inspiration.
What is Murphy's point?
Shetty, you
What is Murphy's point?
Murphy's point, Murphy's sign. Shetty was about to tell something. Aron, you know what is Murphy's point?
2/3 from like 2/3 and 1/3 from
that crossing costal cartilage. That's a
So the right costal margin, the mid
costal margin. What is the right costal margin? Murphy's point is where the rectus, right anterior rectus abdominis cos the ninth costal cartilage. That's a Murphy's point. The other line. As Dr. VT said,
Ask the patient to breathe in deeply and palpate for the Murphy's point. At the height of the inspiration, the breathing stops with a gasp and mass is felt. This is Murphy's sign. The Charcot's right is a right epiglottal pain, fever and chills, and jaundice are suggestive of ascending cholangitis.
Aaron, your Murphy sign is not correct. Murphy sign is only inspiratory catch felt in the region. So you have to read up Murphy sign. It is not what you told. There is no mass, nothing in Murphy sign. Okay. You have to be careful about that sign. Murphy sign is different. Inspiratory catch felt in that Murphy's point in a patient with a acute cholecystitis. That is Murphy's. Okay, sign. Continue, please.
yeah, and don't say stops respiration and all. That's not the word.
Please continue.
So, small bowel obstruction, the common cause by postoperative adhesion, incarcerated hernias, IBD and malignancy, characterized by sudden colicky periumbilical abdominal pain, associated with the nausea, vomiting, which cause temporary relief for the symptoms. Frequent bilious vomiting with epigastric pain, proximal bowel obstruction. It's a crampy periumbilical pain with infrequent feculent vomiting, suggestive of distal intestinal obstructions. Auscultation patient with a small bowel obstruction frequently thought to be characterized by hyperactive bowel sounds and audible pressures. Leukocytosis and lactic acidosis suggest intestinal ischemia or infarction. Plain films of abdomen are diagnostic when they reveal dilated loop of small intestine with air fluid levels and decompressed distal bowel and colon.
What are the normal fluid levels seen in a planetary abdomen erect in a normal person? How many levels are seen?
Less than 2.
2 to 3, sir. More than 3 is abnormal.
So what are the normal? So that means 3 is normal. So where do you find the 3?
Splenic flexure, hepatic flexure.
So all in the colon only. What are the 3 normal fluid levels seen on a plain extra abdomen erect? Usually, classically fundus. Everyone knows.
Yes.
Sometimes in the duodenal and sometimes in the terminal ileum. These are 3 places where we find normally air fluid levels, but beyond 3 is generally considered pathological. Okay, continue please.
So acute diverticulitis, about approximately 80% of patients will be more than 50 years, present with a constant dull aching pain in the left lower quadrant along with the fever, history of constipation and or obstipation. On examination, left lower quadrant tenderness or mass can be felt. CT is reliable investigation for the diagnosis, and we have Hinge's grading. That is, grade 1 confined to pericolic abscess, grade 2 is the distant abscess, and grade 3 generalized peritonitis caused by a rupture of pericolic or pelvic abscess. Grade 4 is the fecal peritonitis caused by free perforation of a diverticulum. So come to acute pancreatitis. Acute epigastric pain that is constant, unrelenting, boring, radiating back and left scapula, associated with fever, nausea, vomiting, comfortable with sitting up and leaning forward, history of alcohol intake or gallstones in the past. Abdominal examination revealed hypoactive bowel sounds, marked tenderness to percussion and palpation in the epigastrium. Will be a great Turner signs or Cullen signs.
So radiation to back is in an acute pancreatitis in how many percentage of cases? It's around 50% only. Radiation to back is more common for chronic pancreatitis and for pancreatic CA. For acute pancreatitis, as per the literature, it's seen only in around 50% of cases. Okay, continue.
Perforated peptic ulcer disease. As many as 4 million people worldwide are affected by the peptic ulcer disease. Of this, many as 5% with perforation. Patient with a perforated peptic ulcer typically present with a sudden onset of severe diffuse abdominal pain. Abdominal examination reveals peritonitis with rebound tenderness, guarding the abdominal muscular rigidity. CT of the abdomen usually suggests the diagnosis of demonstrating edema in the region of gastric antrum and duodenum associated with extraluminal air. Acute mesenteric ischemia result from occlusion of a mesenteric vessel as a result of embolus or a primary thrombosis of a mesenteric vessel, commonly affect the superior mesenteric, presumably because of the less acute angle of origin from the abdominal aorta. Non-occlusive mesenteric ischemia result from inadequate visceral perfusion and can also lead to the intestinal ischemia. Abrupt onset of intense cramping, epigastric, and periumbilical pain out of proportion to finding on abdominal examination. CT angiography is the best initial diagnosis test for suspected acute mesenteric ischemia. Abdominal compartment syndrome, defined as pathological elevation of intra-abdominal pressures. Normal abdominal pressure is 5 to 7 millimeter of mercury, may be higher in obese individual. Intra-abdominal hypertension defined as abdominal pressure of more than or equal to 12 millimeter of mercury. Abdominal compartment syndrome is defined when visceral perfusion is compromised by increased intra-abdominal pressure. Most prone organ is the renal. So the major cause of the abdominal compartment syndrome is mainly divided into three. That is,
just exclude this. Just move on.
Yeah.
Just take out all this.
So,
And I think that stop with acute abdomen. Don't go for any others.
Okay. Next.
So this is a conclusion of all the this is explained below.
Okay, you can summarize.
Yeah. So appendicitis, this is the pain will be a gradual onset. Location will be in the periumbilical area early, and later it will be in the right lower quadrant. So diffuse, early localized, and aching type. The gradient will be of 2. Cholecystitis, which is an acute abdominal pain, is mainly in the mid-epigastrium or right upper quadrant or right scapular region. It's a localized pain and constricting character and radiating the scapula. Pancreatitis is acute pain, is mainly in the epigastrium, T10 to L2 area of the back, localized and boring type, and radiates to mid-back. Diverticulitis is a gradual onset pain, mainly in the left lower quadrant, localized, aching type, non-radiating pain. And perforated peptic ulcer is a sudden onset in the epigastrium, localized early and diffuse later. It's a burning type of pain and non-radiating type. Small bowel obstruction, it's a gradual. Periumbilical pain will be in the periumbilical area. It's a diffuse, cramping type of pain, and it's a non-radiating pain. Mesenteric ischemia or infarction, it's a sudden pain in the periumbilical region. It's a diffuse type, agonizing, and non-radiating. A ruptured abdominal aortic aneurysm, it's a sudden pain, mainly in the abdomen, upper abdomen, back, and the flanks. It's a diffuse type, tearing type of pain, and it's a non-radiating. Gastroenteritis is a gradual periumbilical area and diffuse, and it's a spasmodic type of pain and non-radiating. And pelvic inflammatory disease is a gradual, either in the lower quadrant of the pelvis. It's a localized and aching type and radiates to upper thigh. Ruptured ectopic pregnancy is sudden, either in the lower quadrant of pelvis, localized and sharp pain and non-radiating. And we have to look for the extra-abdominal causes of abdominal pain. There is a myocardial infarction, diabetic ketoacidosis, pneumonitis, esophagitis, porphyria, uremia, and herpes zoster.
Okay. So I think we will discuss chronic abdominal pain. So
no, we won't discuss this. No, because it will be too long. No, sorry, 9
too long. Okay. Anything else?
How many more slides you have?
So, ma'am, only 8 more.
Because you have only done cut and paste, you know. You should never ever cut and paste. Your entire slides are just cut and pasting. That's not the way to prepare slides. That's why you're not able to summarize it.
Because we are asked the same question to you, Aaron, earlier. What are the causes of abdominal pain which are due to metabolic, etc., etc.? And you are not able to answer, but it is there in the slides. Understand? So whatever the things are there in the slides, you must be absolutely thorough. Because you have to, it's not just putting those things by cutting and pasting. Our aim is actually to make you thoroughly read the topic so that you are an expert. Subsequently, once you read that topic, there should not be any doubt whatsoever left on the topic of abdominal pain. Okay, so presenting and putting in a PowerPoint is a different issue. You may copy paste, but generally avoid putting tables as such and all. It won't look nice. But our aim is to make sure that you people read the topic, make it thorough so that it will stick with you for the rest of the life. Okay. So whenever you make a presentation, try to read and make the topic. Ideally, the way in which you should do is that you should read the topic repeatedly, many times, and try to put the PowerPoint in your own language by typing it out. Then it will be original. And you will know everything what you have put in, because what is from your memory you are putting it, and occasionally you refer back and add on points. Okay, then it will stick with you forever. You have made a nice attempt. How many more slides you have?
So 8 more, sir.
Just run it rapidly. Let me see it. Okay, I think in this the only one perhaps important is anterior abdominal wall pain, which again present repeatedly with recurrent abdominal pain, and unless you are very careful, you will miss it completely. You will investigate in great detail, you will not find. This is what is Carnot sign.
So current sign, you ask the patient to lie down, and when the patient elevates his leg above the bed, and the patient will be a severe tenderness will be there.
So you have to first identify the site of pain.
Sites.
Then ask the patient to
lie down
tight by lifting the leg or lifting the head or both, and then press over the area patient locates to, and the pain will be more, and it is generally due to
because of the nerve entrapment will be there.
What is narcotic bowel syndrome?
So narcotic bowel syndrome with the patient usually happens in the young individuals. Post-operative period of the patient is when chronic use of the opioids, either withhold or reducing the drug will cause the pain.
It is increasingly being recognized because of the widespread misuse of drugs nowadays. Okay. Yeah. Just what is the slipping rib syndrome?
So slipping rib syndrome.
Can you just show that slide? Yes. This is due to excessive mobility of the cartilage or the lower costal margin. Okay, sudden severe pain and sometimes tenderness. Next one. Okay.
It's costochondritis, no? Very important. The costochondritis can cause very severe pain, low costal margins.
And there will be local tenderness there. Okay, I think we have covered most of the cases. So, Hari, please. Ma'am, before Hari does the vote of thanks, ma'am, please summarize the points which you have found and areas of improvement which required.
So I think this particular case was not an ideal case for abdominal pain discussion, because you had the spleen and you had the diagnosis. So anyway, the theory part was okay, but you won't get any of these acute cases, okay? Neither will get acute appendicitis, or most of the times it will either be a functional abdominal pain or a pain that is inflammatory or infective. That's all. And then you'll have partial small bowel obstruction. So the focus has to be just towards that. Acid peptic disease, epigastrium, right hypochondrium. And then once you've seen the case, try to build up the history towards your diagnosis. And on examination, if there was no tenderness, then you have to go slow on you cannot highlight the pain as an important presentation. That's very important, because there's no tenderness anytime. at any point of time during examination. And this patient had ascites, so abdominal distension should have come in there. And once the case is known case, it was not the right case for discussion of abdominal pain. Anyway, at least the theory part was okay. It was fine. Yeah. And don't make too many, like, you cannot say diffuse and continuous and then say something aggravated with food, continuous pain aggravated with food, or reduces after, more recently decreasing after food intake. Build up the history in such a way that you're getting a luminal symptom. A luminal food intake and all is luminal. It's got nothing to do with solid viscous. For example, a liver pain will never be related to food intake. It will be more related to respiratory excursion, lying on one side, lying to the other side. There'll be heaviness if there's a tumor. There'll be a catch on deep inspiration if there's an abscess. So those are the things you have to highlight so that you focus your attention towards liver or to the gallbladder. Okay, I think as we go along, we see the cases, probably we can discuss once again.
Yeah, because they are doing it for the first time, no? Probably some mistakes are expected. Don't bother about, don't worry too much about what you have told. Whatever you have told is for your improvement. Understand? I don't think that we are angry with you or we are antagonist and all. So we want you people to do a wonderful job as doctors as well as students, residents in your exam as well. So we want to make the training part a little tough so that you will perform very beautifully well in your examination part. Okay. So those who are cured in the fire will not wilt in the heat. That's our policy. So both of us may be a little tough. Okay, don't get upset about it. So for those who are probably present in future, please take a case with the dominant symptoms of that particular, so that there will be scope for a lot of discussion and it will be more useful. So over to Dr. Hari. Hari, are you there?
BT, why are there only 26 participants?
Only second years and first years. Final years are all in exam mode.
No, second years and first years cannot be just 26, no? And I think we're doing a lot of favoritism by, writing where do you get it, and then they sit and relax and listen. And here we are sitting live for 1.5 hours.
Yeah, there were around, I think nearing 50
right.
to begin with, but they have disappeared now.
It's not
Dr.
right.
Hari
It's
seems to
not
be there.
right.
So on behalf of ISG Kerala Chapter, I thank Jayanthi ma'am for joining us for this case masterclass, and also thanking Aron V. Thomas for presenting this case, and the discussants Vishwas and Sanjay. Thank you very much. And our next session will be on Thursday, ma'am.
I think so. Yeah, that's what.
Thursday.
14th.
What is being discussed?
Thursday, sir.
I don't know what's the topic.
Okay, please let us know. So please put the notice. It's only 2 days from now, no? So please put up the notice. Okay. Thank you very much, and good night to all of you. Bye. And I have Nipah scare again, ma'am. The Nipah is always occurring within 20 kilometers of my hospital. First time it was there. Now also it's there. Nipah, 2 cases which are confirmed.
I just saw that. Yeah, I was just seeing the news.
2 confirmed deaths due to Nipah, and 3 more in the hospital, medical college.
Pull up your mask now.
Yeah, definitely. Okay, good night.
Stay safe. Bye. Bye.
Good night.